Thank you for joining us today for this webinar presented by the American Addiction Treatment Association in collaboration with Nelson Hardiman. I'm Harry Nelson. I'm here with my colleague, Catherine Russo. Our topic today, where social model addiction treatment and practice of medicine intersect, is part of an ongoing series of regulatory compliance issues relevant to addiction treatment programs. In this presentation, we'll discuss navigating the laws and regulations that govern both health professionals and treatment programs. Although we address the issues generally, it's important to take note of specific laws and regulations in your jurisdiction that may be distinctive. The information we discuss today is not intended to provide legal advice and should not be relied upon as such. Listening to or watching this video does not create an attorney-client relationship with either of us or our law firm. And as always, we recommend that you seek knowledgeable legal counsel that take the law of your particular jurisdiction into account before acting on the information in this presentation.
So in this presentation, we will discuss why the laws and regulations governing health professionals and treatment programs matter, the scope of services for drug and alcohol treatment programs, the scope of services for licensed health professionals, the role of physicians and mental health professionals in addiction treatment programs. We'll also give you an overview of the corporate practice of medicine laws in California and the provision of incidental medical services, the role of professional corporations and management service organizations, and finally we will discuss enforcement issues of how to get paid.
So we wanted to say a word first about why we're covering this topic in the first place and why this topic matters. In the aftermath of the Affordable Care Act and the extension of insurance coverage as part of the minimum essential coverage for all health plans, the addiction treatment industry has grown explosively. And while that has had many positive consequences in terms of access to care, it has also highlighted problems. And one of the most serious problems has been patient safety issues, including a rising number of deaths in facilities in California and nationwide, and in particular, deaths that are attributable to non-enforcement of laws related to medical professionals and the relationships between doctors and other health professionals and treatment programs. It's very interesting because we've seen a radical shift in policy perspectives on this issue that we're going to be discussing today. And as an interesting starting point of where California was 4 years ago, the best place to look is the 2012 report entitled Rogue Rehabs, put out by the California Senate's Office of Oversight and Outcomes report. That report details patient deaths in addiction treatment programs, cases of overdoses after discharge, suicidality, and a whole series of problems that were attributable to non-compliance with the laws relating to how medical professionals operate, and the distinction between the rights of addiction treatment facilities and programs on one hand and health professionals on the other as a result of their separate and distinct licensure and certification. The issue has gotten growing attention. As we're going to discuss today, there has been a significant change in California's law in the last year. There's still significant inconsistency across the country on this issue. So in your jurisdiction, you may be, if you're not in California, you may see things that are similar to what we described today, or you may see states that have already moved in the direction of a more integrated approach. In any case, when addiction treatment facilities operate unlawfully, they expose themselves and the health professionals that they work with to both liability and licensing risk. And when we say liability, we're referring specifically to the potential for personal injury claims, wrongful death claims, and potential malpractice liability on the part of health professionals. And when we talk about licensing risk, we're talking about the risk of revocation of license and essentially the closure of addiction treatment programs or the inability of health professionals to practice their professions as a result of operating out of compliance with laws. And finally, if there's ever a reason to pay attention to something, whenever the public and the media are interested in the subject, you can rest assured that it's going to be a higher and higher priority for government agencies. So if the subject of patient safety isn't enough, the fact that government is paying close attention and that the rules are shifting as a result of that attention should make this program interesting and worthy of your attention.
Now that we have explained why these laws and regulations matter, let's discuss the scope of services that non-medical drug and alcohol treatment programs may provide. As Harry mentioned, every state establishes a distinct set of services to be provided by non-medical addiction treatment programs. Some states mandate provision of physician oversight. One example is Florida. In contrast, California limits the scope of services to non-medical services. Programs are strictly social model programs, which means that they may only provide non-medical recovery, treatment, and detoxification services. Treatment in this context refers to group, individual, or educational sessions, recovery or treatment planning, and other individualized services. Treatment in this context does not include anything that is the practice of a health professional, that is the practice of medicine, psychology, or other mental health profession.
We wanted to, as an overview, tie this presentation today into some of our other presentations and to explain from a lay perspective how these different licensing schemes fit together. So in every state, to practice a particular profession or to operate a particular kind of business, a state license may be required. And within the framework of services that are typically provided to people in recovery from addiction, we've essentially broken down 4 categories of licensed services. In the top left, there are health professionals who are providing services. The physicians who are providing services in California are licensed by the medical board. If a psychologist is providing services, he or she is licensed by their own board, the Board of Psychology. And finally, if social workers or MFTs, marriage and family therapists, are providing services, they are licensed by their own agency, the Board of Behavioral Sciences. These are only a small subset of the various health professional licensing boards, and we call attention to them only because these are the most prevalent health professionals and health professional licenses that are relevant in the addiction treatment program, context. And these various licensing boards are all subsumed in California within a single department, the Department of Consumer Affairs. They each operate independently, but have a similar structure of how they regulate professionals. And as we're going to discuss, each of these professionals has a particular scope of practice, and in some cases, either supervision requirements or supervision or the ability to supervise other people. Okay, turning away from the upper left quadrant to the other 3, we have California has 3 distinct agencies that regulate various types of facilities. And again, in some states you'll see similar divisions. In several states there are more unified structures. On the upper right, I listed the category of healthcare facilities. The most classically think of hospitals, including chemical dependency recovery hospitals, which focus on medical inpatient detoxification. Also, in some cases, you may be familiar with congregate living health facilities, which are smaller, 12 to 16 bed facilities that focus on also often on various serious disorders where people need a higher level of nursing care. These agencies are all regulated by the California Department of Public Health, which regulates healthcare facilities. The healthcare facilities are distinguished in California and in many states from residential care facilities, which is the lower left quadrant. Residential care facilities are licensed by a completely distinct agency, the California Department of Social Services. In this category, you'll find things like group homes, which in California are the appropriate framework for treating people under the age of 18. Also for adult residential facilities and social rehabilitation facilities and other kinds of residential care facilities that operate sometimes in connection with addiction treatment programs. What's important to note is that there are distinct services that are provided in each context. Healthcare facilities are allowed to do a significantly more expansive range of services involving different kinds of health professionals. Residential care facilities have no scope of practice that includes health professionals like nurses, and instead are really operated by program managers. They do have requirements of what their programs must and facilities must maintain, but they are very distinct. And finally, we come to the primary category in California of addiction treatment facilities, the social model, what we've been calling social model programs. Now, these are not referred to as social model in California law, we're using that term to differentiate them from these other categories. And we'll talk on a future slide about what we mean by social model. But this, this area was covered until 2012 by a distinct agency called the California Department of Alcohol and Drug Programs, which people who have been around may remember. Since 2012, that agency no longer exists, and these programs are now regulated by the California Department of Healthcare Services under its SU, its substance division. It's interesting to note that the California Department of Healthcare Services is generally known to most people as the agency that regulates the Medicaid program in California, which we call Medi-Cal. And you may ask yourself, why is it that California, when it closed the Department of Alcohol and Drug Programs, decided to assign substance use disorders, assign addiction treatment to an agency that was not generally in the business of licensing facilities when there already were agencies like CDPH and Department of Social Services that were doing so? The answer is because a significant component of the Medi-Cal program was the drug Medi-Cal program. So based on the fact that the Department of Healthcare Services had experience dealing with substance use disorders in the Medi-Cal program, it was reassigned and took responsibility in this SUD, Substance Use Disorder Unit, for licensure of residential treatment programs and certification of outpatient programs. So what's critical to note here is that depending on what kind of facility you have a distinct set of permitted services to you. And again, those services come with distinct personnel requirements and distinct supervision requirements in some cases, and those are very distinct from health professionals. Health professionals are not licensed as a facility. They are licensed as individuals and empowered by virtue of their license to provide a distinct set of services, namely the practice of their profession. So we hope that this is useful in terms of understanding the intersection of different services. When you put together your program, it may fit neatly into one of these 4 boxes, or it may be the case that you are actually constructing a program which combines some scope of practice from health professionals with one of the other 3 categories that we've listed on this stage. And when that's the case, you need to make sure that you are operating consistent with both regulatory schemes, that is the facility licensing and the professional licensing. And you also need to make sure that you aren't violating any laws that limit how those facilities work together. And as a final note on this slide, the one category that we've left off is the unlicensed category of facility, that is sober living. And so sober living has yet its own set of distinct services. Sober living is not a context which envisions any role for health professionals, and we'll talk more about that on a future slide. Having reviewed the distinct licensing schemes which are relevant for both health professionals and facilities, it's important to also discuss the distinct reimbursement codes, because these are a subject of frequent confusion. So health professionals, by virtue of their license, are permitted to bill their services directly under what are known as CPT codes, or current procedural terminology. Those are codes developed by the American Medical Association, and they cover anything that health professionals typically do. The most common codes for physicians are what are known as E&M codes, or evaluation and management codes. These are generally 5-digit codes that begin 992, and the final 2 digits distinguish whether it's a new patient or an existing patient and the level of service provided. Many people may be familiar with the 99211 being a very short visit, 99212 being a longer, more complex visit, and so on, all the way up to 99215. These are visits that are distinguished by not only the length of time, but by the decision-making that's involved in diagnosing the patient and recommending treatment after the taking of a history and the physical examination of the patient. So those are codes that are available to physicians, and there are also many codes that are available specifically to mental health professionals, including various psychotherapy codes and counseling codes. So those are individual professional codes, and it's useful to distinguish those from the HCPCS codes, which are healthcare common procedure coding. This is a set of procedure codes that are based on the CPT but are distinct and are intended for facility-based billing. They identify facility-based services as well as products and supplies, We call these the HCPCs. So these codes, what's significant here is that these codes come in very different levels, including multiple levels of detoxification codes, residential treatment codes, and then some of the most commonly billed codes are PHP or partial hospitalization codes, and intensive outpatient and outpatient codes, IOP and OP codes. What's interesting, and the reason that we're putting this up is because often all of the various HCPCS codes involve professional services on different levels. For example, in a detox setting, there may be a requirement of a certain level of nursing hours that need to be provided to qualify for the billing level and the coverage requirements established by the health insurance plan. Similarly, in a PHP, a partial hospitalization program, there may be a requirement of a certain number of individual or group counseling hours, and most commonly, those hours are provided by counselors who are mental health professionals. They can, of course, be provided by unlicensed health professionals, by, for example, certified drug and alcohol counselors. And we're not covering that category today because we're focusing on health professionals in this program. But the interesting thing to note is that there are the same services may be billable in distinct or overlapping ways. This is important because first, you have to avoid redundant billing that charges insurance companies twice for the same service, which would be a form of fraud and abuse, but also because there are choices available in how services are billed. And it's important to work with billers and coders who are knowledgeable and understand the various requirements and advantages and disadvantages that go along with these codes. But the codes are interesting because they highlight the overlap in some categories between forms of services that are billable through addiction treatment programs and by health professionals. With this overview in mind, we wanted to highlight the key regulatory questions that need to be asked by both health professionals and addiction treatment programs whenever they're confused or exploring what licensing and certification is required. The first question is, what program license or certification, if any, is required to provide a particular set of services? And the second question is, what personnel licensing or certification is required? Again, physicians, psychologists, mental health professionals are all entitled under their individual personal licenses to provide a particular set of services. But it's important to ask what program licensing may be required for a particular residential facility or a particular activity, and what personnel licensing is required. With regard to both of these, it's important to ask what are the scope of practice limits that are inherent in every particular license. Every license comes with a defined set of services that the licensee, whether it's a licensed facility or a licensed professional, is entitled to provide. In some cases, no license is required, and all that's required is a certification. In some cases, a certification is optional, but an insurance company may insist upon it. So after the scope of practice question, the next question is, what supervision requirements are imposed on the personnel involved? Is there a particular person who needs to be generally available? Do there need to be particular documented approvals that a particular person was reviewed and confirmed by somebody with a higher licensing level for the service that they're going to be provided? How do they need to be monitored on some particular level? What documentation requirements may apply, and what other safety standards may apply? These are all questions that need to be asked. These are what we think of as lawyers. We think of these as regulatory questions as it relates to how an addiction treatment program runs and what health professionals do. And I want to note that these are distinct from the questions of risk management and best practices for liability. That is to say, the questions on this slide are all questions that government agencies are focused on when something goes wrong or when an investigation occurs. Those are distinct from the kinds of claims that may be brought by individuals who believe they've been injured, or by families who are upset about services. Liability questions are closely related and may often be triggered by failure to comply with these requirements, but it's a distinct set of questions on a risk management level about what the best way to operate is. These questions are questions that go to what's legally required from a state perspective to provide the services. And I also want to note that those are distinct from questions of what kind of billing is appropriate, right? The requirements for billing are to submit claims to payers only for services that you are entitled to be paid for. And so those, again, those reimbursement questions involve regulatory issues inherently, because a particular claim may not be appropriately billed unless the billing program has the necessary license or certification, or the person, the health professional billing, had the necessary license and certification. But again, that may only be part of the question, and there may be other requirements for billing. So these three subjects of regulatory licensing and certification, risk management and liability risk reduction, and billing compliance are separate and distinct but interrelated.
With this broad overview in mind, we want to get to the specifics of the scope of services for different types of licensed health professionals. The scope is defined differently for each of the professions. For example, an MD or DO, a psychologist, a marriage and family therapist, or a licensed clinical social worker. Other than roles of registered nurses or licensed vocational nurses in detoxification programs, there is no practice of any profession in the scope of drug or alcohol treatment services. For example, a licensed clinical social worker could run a group counseling but not be considered to be providing psychotherapeutic counseling under the auspice of the treatment program. Provision of other clinical services outside the program's scope constitutes an unlicensed practice of medicine, or the practice of a licensed profession by the program, and it is considered aiding and abetting unlicensed practice by the responsible professional. This must be done in accordance with the corporate practice of medicine rules. So what is the role for physicians and mental health professionals in non-medical addiction treatment programs? This may differ depending on the state. In California, prior to the passage of AB 848 in October of 2015, treatment programs were prohibited from contracting with a physician to provide clinical services to clients. And we will discuss the details of AB 848 in a later slide, and we will also discuss why AB 848 is a game changer in the addiction treatment space. That being said, physicians have always been permitted to provide non-clinical directorship services to addiction treatment programs, and such services are recommended. The directorship services should be carefully spelled out in a contract to prevent the violation of the corporate practice of medicine doctrine. And services generally include things like developing and implementing quality assurance and quality improvement programs for the program, assisting the program in establishing and enforcing standards, policies, guidelines to ensure quality of services are being delivered, assessing the quality of services provided by the program personnel, and also instructing and educating the program staff on how to recognize withdrawal signs, and generally educating them on the effects of drugs on the body during withdrawal.
And as a shorthand for all of the services that Katie described that are appropriate directorship services that are non-clinical, the things that you have to avoid having a clinical director who is not in a situation where they can be practicing their profession provide are diagnosis and treatment. So when we recommend or suggest that a non-clinical director, a non-clinical medical director, for example, may be an appropriate role, this is not in any way blessing the diagnosing or prescribing or other treating of patients by that director. The role of the director is really a supervisory role, and it highlights the extent to which there is some confusion over the lines between social model treatment and professional medical treatment. We wanted to talk about the corporate practice of medicine doctrine that comes up. Now, corporate practice of medicine is a doctrine that exists in the majority of states around the country. It looks a little bit different in virtually every state. California is a state that's particularly formal and serious about the corporate practice of medicine. The basic rule of the corporate practice of medicine is that doctors and other licensed health professionals are not permitted to practice their professions as employees of corporations or other entities. That rule translates in California into a rule that doctors and licensed health professionals may not be contracted or employed by unlicensed by general business corporations or limited liability companies. And that includes addiction treatment programs, whether outpatient or residential. The only corporate form that's permitted in California for a doctor to be employed or contracted is a health professional-owned professional corporation. And California, like many states, has very specific laws of who may own a professional corporation, how it must be named, and how it must be governed. And there is no role in California for unlicensed people to be shareholders or directors in a professional corporation. And so doctors really, in most parts of California medical practice, doctors may either practice as sole proprietors or as shareholders of a professional corporation or as contracted or employed doctors for a professional medical corporation. And those are the permitted forms of practice. And any kind of contracting or employment by any kind of other entity is generally problematic.
So as Harry mentioned, licensed health professionals may only be employed by a professional corporation. So let's get into some of the specifics. Pursuant to the California Corporations Code, 51 to 100% of shares of a professional corporation must be owned by an MD or DO licensed in California. 49% or less can be owned by a California licensed registered nurse, physician assistant, podiatrist, and a bunch of other types listed here on the slide. Unlicensed people cannot be shareholders or directors of a professional corporation. If the professional corporation has only one shareholder, which is common, an unlicensed person can hold an officer position of vice president, chief financial officer, or secretary. And an unlicensed person can hold titles of executive vice president, CEO, or any other title that makes clear that they have an administrative function within the professional corporation.
And it's also important to note for other health professionals, that is, for example, for psychologists or marriage and family therapists, there are other categories of professional corporations. California is a state that in the Moscone-Knox Act lists out numerous types of professional corporations. It's interesting to note that in various states around the country, the corporate practice of medicine doctrine is shrinking and does not apply to as many professions as it does in California and other states that are more aggressive corporate practice states. So it's very important to pay attention to whether professional corporations are required in your jurisdiction, and if so, whether they're required for the particular practice and who's allowed to own them and how they're governed. Now, we wanted to turn to unlicensed people, unlicensed persons and programs, and the phenomenon of the management service organization. Now, this is relevant because in most contexts, other than addiction treatment programs that are owned and operated by licensed health professionals, the people running addiction treatment programs, both residential and outpatient, tend to be unlicensed, and the entities themselves are deemed to be non-professional. They are general business entities. So the Management Service Organization, or MSO, is a type of organization that has arisen as a way for professional corporations and health professionals to work with unlicensed people who are providing key services in the organizations. MSO is not a term that's defined in any statute in California or in most parts of the country. It's a descriptive term that describes the business relationship. And as the name suggests, the whole idea is that a distinct entity, which is owned by unlicensed people, or owned in some cases in a shared combination of licensed health professionals and unlicensed people, they own the MSO, and they use it to provide non-clinical support for health professionals and for professional corporations. And so, for example, in the diagram that we've put here, we've essentially outlined how services are provided. A patient comes to needs services from a health professional. The health professional, as represented by the PC or professional corporation, provides services and accepts payment for services. And then generally the financial structure is that the PC will then pay a management fee to the management services organization for those services. And those services can be things like billing and accounting, other administrative services. In some contexts, they can involve marketing, although that is a uniquely complex issue because of various state laws and is something that needs particular attention. And they can provide a host of other services. In California, they can lease space on behalf of the professional entity and lease equipment. There are all kinds of non-professional services that can be provided and assets that can be provided by the MSO to the PC. And the function that this achieves financially is to enable unlicensed persons to derive some share of revenue from the services that they provide. And in California, as in most states in the country, the management fee may never be tied to the volume of patients that are generated or referred for professional services. In California, it can be a flat fee or a percentage of gross revenue relationship between the professional entity and the management entity. This is important to note as distinct from a number of states which prohibit percentage-based relationships. And the rule in California is that the management fee has to be commensurate with the value of the services provided from the MSO to the professionals. With this overview of the ways that professionals and unlicensed persons, and including health professionals and addiction treatment programs, may work together, we wanted to turn to some of the significant changes that have happened in California law. And the source of pressure for change at the beginning of the program has been increasing concern over patient safety issues, both as a result of the confusion over how addiction treatment programs and health professionals are supposed to be working together, and how patients have been endangered. And as we're going to see in the issues that were tackled by the new law that California passed, there are particular issues that were a focus. And again, these are based on historical cases where the perspective of the state of California is that patients died or were exposed to serious harm because laws weren't being followed about where the limits of physician treatment are and where the limits of a social model addiction treatment are. There was a concern, as we mentioned in this 2012 report, for general disregard for the rules, which was manifested by outpatient and residential programs routinely hiring doctors and having doctors provide services directly to patients under the auspices of their programs. One thing that was interesting to note was that report in 2012 was somewhat outdated in its understanding of addiction treatment and what kind of patients are coming to social model addiction treatment programs. And the report essentially was adopting an older view that social model, that is counseling, treatment, services, should be distinct from medical treatment. And there is a growing recognition that these are interwoven issues. And that was finally addressed, as Katie noted on an earlier slide, by Assembly Bill 848, which was enacted in October 2015. We're in an interesting period because the Department of Healthcare Services was given until July of 2018 to fully adopt implementing regulations for the changes that we're going to discuss.
So as a reaction to this pressure for change, as Harry mentioned, AB 848 was enacted, and this is a game changer for the addiction treatment space. Its passage represents a recognition that the current framework was endangering patients. Under AB 848, residential addiction treatment programs are authorized to allow physicians to provide incidental medical services to residents under limited circumstances, including medical appropriateness at intake into the program. Physicians are not permitted to provide general primary care, so that's important to note. This amendment to the Health and Safety Code will require health professional certification of residents as a condition of providing incidental medical services. New Health and Safety Code section 11834.026 defines incidental medical services as addressing medical issues associated with either detoxification from alcohol or drugs or the provision of alcoholism or drug abuse recovery or treatment services, including taking medical histories, ongoing monitoring health status for need for urgent or emergent care, testing for detox, overseeing patient self-administered medications, and treating substance use disorder and detoxification. And Harry will now discuss the difference between the old paradigm and the new paradigm after the enactment of AB 848.
So on this slide, you'll see on the left essentially what the paradigm for addiction treatment and medical care was before Assembly Bill 848, and on the right, what it is after. So going line by line, before 848, the medical director services role was, as we described on a previous slide, was strictly limited to non-clinical directorship services. There was no ability for a physician or other health professional to diagnose a patient within an addiction treatment program, and no right to treat or prescribe medications. Under the new paradigm, medical directors or any other contracted health professional who's appropriately licensed is required to take a medical history, certify medical appropriateness at intake, and is authorized to provide clinical services. I should note that the certification goes along with the provision of services. If a addiction treatment program is providing services to people who are at a lower level of care and those people do not need incidental medical services, there is not a requirement that incidental medical services must be provided. However, if incidental medical services are going to be provided, then the certification must be completed. So the next requirement so there's a changing role of the medical director. So the first significant requirement is actual monitoring of resident health. And again, in the pre-848 period, until October of last year, the facilities had no right, addiction treatment facilities had no power and no scope of practice that allowed them to monitor the health of their residents. That was supposed to be strictly a matter of the resident and his or her health professional, his or her doctor. Now, a certifying physician is required to actually check the patient out at the point of intake and to monitor that patient's health status to assess for the need for elevated care. And this is one of the most widespread patient safety issues that's been identified. That is, times when when a patient's health requires examination and potential care to be provided in an urgent care setting or in an emergency room setting, and there was a concern that too often these decisions were not being made by people who were qualified to make them. So that's a significant change. So again, as I noted, in the pre-848 period, patient-physician or patient-health professional relationships were required to be completely independent of the facility. A patient was required to choose and contract with a physician independently. In the post-848 world, facilities are now, again, in a case where facilities are going to provide incidental medical services, they're required to assign and have a physician available to provide those services. So this is a significant carve-out from the corporate practice of medicine rule, essentially allowing physicians, and in some cases requiring them, to have physicians available and to contract with those physicians. Patient medication management in the pre-848 world was perhaps the most confusing subject of all. Many times people present to addiction treatment programs with complex medications that have been prescribed for them. There is often a need to assess whether those medications are appropriate, whether there's a risk of dependency or health issues with particular medications, but the facilities had no right to manage patient medications, and facilities were quite limited in what they could do. Now, under new law, the certifying physician is responsible to oversee the patient medications. We should note that the medications remain self-administered in a residential treatment context, and we're talking about strictly in the residential context. None of these rule changes apply in the outpatient program context, which may be a subject for a future presentation. But in any case, the medications are now monitored by the physician. They are reviewed for appropriateness, prescribed and renewed by the physician. The patient is still self-administering the medications, and the facility is not permitted to directly administer medications. That remains the case. And finally, in the pre-848 period, documentation of a treatment program and medical treatment needed to be completely separated and distinct. There was no role for addiction treatment programs to be involved in the medical care for their residents. And in the post-848 period, the medical histories and this specific certification form will be required to be stored at the treatment center for review in the event of an investigation by DHCS.
So now that we have explained the new paradigm, the question becomes, before AB 848 is implemented by the Department of Healthcare Services in 2018, what should addiction treatment programs do regarding physicians? There are two options. One, programs can expand the medical directorship role now without waiting for DHCS to implement the regulations, or two, programs can require patients to select and designate a physician. We believe either option is appropriate, although the second option is a safer choice. If you decide to have your client select and designate a physician, make sure that you document that it shows the doctor. Make sure that there is a separate agreement between the physician and the client. And also, it is important that you pre-screen clients before intake to make sure that their services are medically appropriate. The bottom line is, do not take chances with patient health issues. It is better to err on the side of caution in referring out clients than to have an incident at your facility.
So we're going to turn from that subject, and it's a difficult question, and in terms of how to act in the period before 848 is fully implemented. But we wanted to turn back to the subject of the question of whether there's still a need for the professional corporation and MSO structure in a post-848 world. The entire point of establishing a MSO for an addiction treatment program is to allow some oversight of non-clinical aspects of clinical operations. That is, to provide administrative support, billing support, financial, marketing, sometimes personnel support to health professionals. And a number of addiction treatment programs in California have elected to use this model. It's important when using this model to be sensitive to the perspectives of state licensing boards, like the medical board, on what clinical decisions need to be overseen or ratified by health professionals, and where a MSO might be infringing upon on clinical personnel. But the bigger question is whether this model still has a place to play in a world where incidental medical services can be directly contracted for and provided by addiction treatment programs. And our view is that certainly 848 has significantly diminished the need for the MSO structure. Many programs took the view prior to AB 848 that they needed to have some way to coordinate physicians to provide a seamless transition between physicians and health professionals and their program, and to really provide an integrated model of care, and they couldn't do so without the MSO. With 848, it's now possible for programs to involve physicians and other health professionals seamlessly within the scope of incidental medical services. So the big question for addiction treatment programs that are exploring or are actively involved in more integrative models that combine both social model residential treatment aspects or outpatient programs with medical or other health professional care is whether the scope of services goes beyond incidental. For example, programs that involve mental health, more intensive mental health services, or more intensive medical services. And as we noted on the previous slide, 848 does not change the scope of practice or relationships between treatment programs and physicians in the outpatient context. 848 is strictly focused on the right of residential treatment facilities as part of their residential care to provide the certification and incidental medical services. If you are an outpatient program and you are trying to understand how to integrate medical services because you believe that those services are necessary and integral to your program, the MSO model remains the only way that you can do so in an integrated form. Otherwise, you are left still with the old model of telling your patients that they need to find an independent health professional and having your patients, your clients, contract directly with health professionals. And this model may not work for all outpatient programs.
We would now like to turn to a brief discussion of potential enforcement issues. First, medical boards are suspicious of sham ownership of professional corporations. So it is important to ensure that physicians have a real participation in their corporations. Key medical functions must remain under the control of the physician owner or a contracted physician to avoid running afoul of anti-corporate practice of medicine statutes. Further, the medical board regards hiring allied health professionals and even medical assistants as requiring physician oversight. And finally, relationships where physician shareholders have no risk and no upside will be regarded as suspect by the board.
We want to talk about a broader set of enforcement issues as well. First, with regard to the issue of physician provision of services in addiction treatment, residential addiction treatment programs, the medical board has not been active since the enactment of 848 in pursuing cases of violation of corporate practice of medicine, but at the same time has made no formal statement. And so there is some lack of clarity about risks for physicians of providing services on a contracted basis in the interim until 848 is fully implemented by the Department of Healthcare Services. And I also wanted to say a word about other licensing boards. In general, we've seen less enforcement activity from the various mental health professional boards, the Board of Psychology and the Board of Behavioral Sciences. And I think that may be because as we discussed on earlier slides, many of the program functions, and particularly PHP and IOP programs, involve mental health professionals, and so there's some recognition that there are legitimate roles to be played by mental health professionals that don't involve the practice of their professions. But those remain legitimate issues, and for any addiction treatment programs that are exploring the PC MSO model, the same points that Katie raised about the role of the shareholder, whether it's a physician, a psychologist, an MFT, or an LCSW, needs to be considered, and there needs to be a good understanding between the licensed health professional shareholder and the addiction treatment program and management service providers of who is allowed to do what. It's a distinct set of scope of practice issues from licensure, but it's important because the licensing boards pay close attention to who's doing what in the context of health professionals and unlicensed persons working together.
So in conclusion, we would like you to take away the following points from our presentation today. The implementation of AB 848 is a welcome change for treatment program and health professional relationships. As Harry mentioned, light enforcement of corporate practice of medicine rules is anticipated but not guaranteed until the full implementation of AB 848, after which stricter enforcement with the new rules is expected. And finally, and most importantly, patient safety should be the paramount issue to avoid endangerment of clients and patients.
And I'd like to close with that thought. Patient safety is really an evolving concept. We're seeing that the nature of addiction treatment patients and addiction treatment clients is changing, and there are significant patient safety risks, not only at the point of intake in terms of deciding how patients should be treated appropriately, but throughout the course of stay, whether problems emerge, and even during the discharge of patients. And these are points of significant risk that puts people's lives at stake, and at the same time presents great risk for programs that don't behave appropriately. So we hope that this program will encourage your facility to, or if you're a health professional, we'll encourage you as a professional to think about how to get towards a point of greater safety. Thank you so much for listening to our program today. We hope you've learned something, and if you have questions, you know where to reach us. Thank you very much.